So chapter 24 is about the urinary system. And this system consists of kidneys, ureter, urinary bladder, urethra, and it has the function mainly of eliminating wastes, preserving water, and interacting with other systems to control blood pressure and to actually stimulate also production of red blood cells and to as well control hydrogen ion concentration among others. So for the kidneys, the details about the kidneys, they are retroperitoneal organs located, of course, in the posterior abdominal wall in the lumbar area. And specifically, the left extends between thoracic vertebrae number 12 and lumbar vertebrae 3. Now, for the right the kidney, it's a little bit lower than the left, is partially protected by the thoracic vertebrae 11 and, by ribs, floating ribs 11 and 12. So it will be located a little bit lower than the left between L1 and L4. So on the superior part, these kidneys have a triangular shape or pyramidal shape gland that is the adrenal gland, and the adrenal gland is also known as suprarenal because it's located in the superior pole of the kidney. Now, the kidneys connect into the urinary bladder with a couple of long tubes, muscular tubes that are called the ureters. The ureters themselves are muscular, and then they perform peristaltic motion, which will be contraction relaxation, to help transfer the urine from the kidneys into the urinary bladder. The urinary bladder will be a muscular organ that is located in the pelvic area just behind the pubic symphysis, and it helps to temporarily store the urine. And the urethra will be a tubular organ that helps to drain the urine outside of the body. Now, at the end of the urethra, we have an sphincter that is called the urethral sphincter. This one, it is made by skeletal muscle cells and is under voluntary control. So here's the location of these urinary system structures. So here we have the paired kidneys in the retroperitoneal space. This is the superior pole where you have the adrenal glands, and then medially the kidneys, they have an indentation that we call the hilum, where the renal arteries comes in, the renal veins comes out, lymphatics come in, and nerves come in. So this is the hilum, and then we have this long extension, the ureter, that connects the kidneys to the urinary bladder. And then the urinary bladder at the neck, this is the neck of the urinary bladder, extends this muscular organ, this hollow organ, which is the urethra, to help to extrude the urine from our body. And this is the posterior view showing you how the kidneys are differently located in terms of level. Of course, we know that they are in the lumbar area, but the right one is lower than the left. Why do you think the right one is lower than the left? Because what?
Because the gland sits on it?
Yes, which gland sits on it and on which side?
The adrenal on the right side?
Well, you have the adrenal on both, right?
Oh, okay.
But that's true, but there is a gland that is not shown in there that makes the right kidney to be lower than the left. Just say the name of that gland. That gland pushes the right kidney lower. I'm waiting.
It doesn't have, no, it doesn't have to do with the liver, does it? Oh, it does? See, is it, I don't wanna say it.
The liver is the largest gland
Oh,
and pushes the right kidney down. And then these lower ribs, the floating 11 and 12, protects at least partially this kidney. We have also the quadratus lumborum muscles that protects them in here. So functions of the kidneys: removal of metabolic wastes like urea, uric acid, ammonia, some cases. Maintaining fluid and electrolyte balance. When you drink a lot of fluids, you go and pee a lot too, so you remove excess of water. If you over ingest sodium, your urine will be salty, etc. So it removes excess of molecules from our body. Maintains acid-base balance, so it regulates how much hydrogen ions do we have. It can preserve hydrogen ions, like if you have alkalosis, if you don't have as much, you bring them back, you reclaim it from your blood. And if you have excess, like in acidosis, you eliminate these hydrogen ions, and then you start forming bicarbonate ions. These bicarbonate ions can absorb this hydrogen, so to get rid of them. Maintains blood pressure. When your blood pressure goes down, you release an enzyme that is called renin that starts a cascade that ultimately leads you to bring your blood pressure up. We will go over the details of this. It regulates erythropoiesis, formation of red blood cells. When someone has anemia, the kidney secretes EPO, erythropoietin, so that your bone marrow produces more red blood cells. Now, if someone is diabetic for a long time and that person didn't take care of itself, then that person with years is going to develop damage to their kidneys. So a person will have end-stage organ damage. And that will lead to lack of erythropoietin. And then the person will be anemic. You can see it in the person, it's pale because it doesn't have as much red blood cells. And also can detoxify substances in the blood, activates vitamin D. So we have vitamin D starting to be produced in the skin, then it goes to the liver, that precursor to be hydroxylated, so you add a hydroxyl group, and then the last part where we add the other hydroxyl group is in the kidneys, so that you can have a form that is active of vitamin D, so that you can absorb calcium. And then make new glucose through gluconeogenesis. The kidneys are protected by some tissue, like the renal fascia. The renal fascia is irregular connective tissue, is the most external layer. And between the renal fascia and the renal capsule is also connective tissue, but the renal capsule will be the one that is in close contact with the kidney. And then in between we have fat that we call perirenal fat. So if someone loses fat very quickly with this crash diet. One of the things that happens is that the kidneys drop in level. So this is called renal ptosis or nephroptosis, because this fat together with this connective tissue helps to keep the kidneys into their proper space. Dimensions, they measure around 11 centimeters in length, a little bit over, or well, almost like 4 inches or so. 6 centimeters in width, a little bit over 2 inches, and 3 centimeters in thickness, like around 1 inch. So it has like the size of a bar of soap and weighs around 150 grams. This tiny organ is very important for life. It helps to detoxify our body. It has the shape of a pinto bean with the convexity laterally and the concavity medially. The concavity is where we have the opening for allowing these blood vessels to come in and out, the nerves to come in, and also the lymphatics. So this is the hilum. And then within the hilum, we have a space that is called the renal sinus. That is where we have as well adipose tissue, and then that anchors the ureter, the blood vessels, and the nerves into place in the renal sinus. This is the transverse cut showing you the kidneys in situ or in its place. So you're looking at the inferior view at the level where the kidneys are located. So this is the abdominal cavity, and this is the lumbar vertebrae. These are the muscles that surround this vertebrae and that protects the kidneys, including the quadratum lumborum. And here we have the right kidney and the left kidney, and then this is the renal capsule surrounding directly the kidneys. This is the renal fascia, and then we have the perirenal fat that helps to protect the kidneys and keep them in place. And then this is the parietal peritoneum. So the kidneys are retroperitoneal. This is for protection in case that someone has a urinary tract infection that goes up to the kidneys, causing what is called pyelonephritis. That infection doesn't go into this cavity. Or let's say that something is going wrong in the peritoneal cavity. That doesn't affect your kidneys. So that's why they are in a special compartment. The internal anatomy of the kidneys. So if you make a transverse section of the kidneys has an outer region next to the capsule that is called the cortex. Just as in any other organ, the most superficial part is called the cortex. And then the cortex protects the most internal region that is called the medulla. And within the medulla, you have pyramids and columns. The pyramids, they have like a pyramid shape, that's why they're called pyramids. And the apex of the pyramids faces towards the hilum, while the base faces toward the cortex. And the cortex is reddish brown in color because it has a lot of blood supply. Between 90 to 95% of the blood vessels that goes into the kidneys are located in this region. And then the renal columns that separates the pyramids is the space where the blood vessels go and distribute their blood supply or their branches of these blood vessels into the cortex. Within the cortex and the medulla, we have over 1 million nephrons, which are the structural and functional unit of the kidneys. Each nephron has a globe-shaped renal corpuscle, and it has tubules that are called the renal tubules. The tubules are subdivided into segments, and they have different functions, the corpuscle and the segments of the tubules. And now, The pyramid tapers into the papilla, which is where we collect the urine initially, and then this papilla is draining the urine into minor calyces or minor calyx. And each of these minor calyces collects the urine initially, and then they fuse or they anastomose, forming the major calyces. And 2 to 3 major calyces, they form the renal pelvis, which looks like a funnel. And this renal pelvis is closely located to the renal hilum, and then the pelvis extends this muscular tube that it is the ureter to bring the urine into the urinary bladder. So here is the internal anatomy of the kidney and the parts of the nephron. So the kidneys are protected by this connective tissue that is the renal capsule. Underneath the renal capsule we have the renal cortex, and then underneath or more internal to the renal cortex we have the renal medulla, where we have these pyramids. And then the pyramids are separated by the columns, which are this. And then the pyramids has the apex that drains the urine into this papilla, and then the papilla drains the urine into these minor calyces. 2 to 3 minor calyces, they merge, they're anastomosed to form the major calyces, and then 2 to 3 major calyces, they form this funnel-like structure that is the pelvis. And then within this pelvis, you drain the urine from the kidneys into the ureter, which is this long tube that goes and drains the urine into a urinary bladder for temporary storage. Something else that you can see here is the renal artery and the renal vein. And then for magnification of this region, so you have here a lobe of a kidney that is made by a part of the cortex, the renal pyramid, and then the papilla and the minor calyx. So you have within each kidney like around 1 million nephrons, and these nephrons are located in different regions. So ones that are closer to the cortex that you call the cortical nephrons, and ones that are closer to the medulla, which are called the juxtamedullary nephrons. Juxta means nearby. So these will be the nephrons nearby to the medulla, which is here. And then this is the pyramid. This is the apex, this is the base faces towards the cortex, the pyramid faces into this papilla, next to this minor calyx. So the nephron has this part that is called the corpuscle, and then it has these tubules. The tubules drain, they absorb water and solutes, and then they drain into these collecting ducts. And the collecting duct drains the urine into the minor calyx. For being small organs, the kidneys, they receive a lot of blood supply every minute, 1/4 of the cardiac output, or what we call the fraction, the renal fraction. So they receive around 1,200 milliliters of blood per minute. And then they receive the blood from the branches of the aorta, the right and the left renal arteries, and then the blood from the renal artery will be distributed into segmental arteries, just deep to the hilum. And then you will have running in between the pyramids these interlobar arteries, and then in the base of the pyramids, the interlobar arteries, they make a turn following the contour of the base of the pyramid, and they form the arcuate, forming like an arch. That's why they're called arcuate. And then out of this arcuate, you have branches that goes like this, radially toward the cortex. This will be the radial or interlobular or cortical radiate arteries. And then from these arteries, you will have the tiniest branches of these that will be called the afferent arterioles or arriving. And then these afferent arterioles will form a tuft of capillaries that will be protected by the renal corpuscle. And this is called the glomerulus, inside the renal capsule, the glomerular capsule. So once the blood circulates inside the glomerular capillaries, they will drain into the efferent or exiting arterioles. And the exiting or the efferent arteriole is narrower than the afferent arteriole. So what it means is that you receive more blood in the corpuscle than what you are draining by unit of time. And that increases the pressure inside the glomerulus. That's what drives the filtration. So that's what helps for getting rid of wastes. And then the efferent are going to feed into these peritubular capillaries that are found around the tubules. So after the afferent arteriole, the blood goes into the glomerulus, then into the efferent arteriole, and then into the peritubular capillaries. And then the blood from the peritubular capillaries will return into the veins by the interlobular vein first, then the arcuate vein that is located in the cortex, and then you have an interlobar vein that drains the blood in between the columns, and then you will have the formation of the renal vein by the anastomosing of these interlobar veins. There is no segmental veins, but there are segmental arteries. And then the renal vein will drain into the inferior vena cava. So here's the pathway of blood. So from renal artery into segmentals, we have like 2 to 3 segmentals. From segmentals into interlobars, which are this. From interlobars into arcuate. And then if you magnify, this is the arcuate, and then into the interlobular or cortical radiate, and then into the afferent or arriving. And then you form this tuft of capillaries, which is the glomerulus. And then the blood exit from the glomerulus into the efferent or exiting. And then you drain the blood into the peritubular capillaries that are around these tubules, and then form the peritubular capillaries into the arcuate vein, into the interlobular vein, which is this, and then into the arcuate vein, and then into the interlobar veins, and then these 3 to 4 interlobar veins form the renal vein, and then into the inferior vena cava. So, function of the nephrons, this unit, the structure and functional unit, will be to filter the blood and modify this filter fluid, eliminating what you don't need and keeping what you need. So reabsorbing what you need, excreting what you don't need. And then transfer all the wastes and water and things that you don't need into this collecting duct. So the collecting duct is not part of the nephron. It collects fluid and modifies it if it's needed. Not all the time it's needed, but sometimes you might need to modify it. Details about the corpuscle. So again, the capillaries that form the glomerulus come from this afferent arteriole or arriving. And these capillaries have fenestration. have pores so that you can filtrate the plasma. And then they are very leaky. Now, this corpuscle has two membranes, a visceral layer and a parietal layer, which are forming what we call the capsule of Bowman's or glomerular capsule. Both of them are made out of simple squamous epithelium, but the visceral layer...
We're going to be making a little bit of noise in the hallway. Do you want me to close the door?
Yes, please.
Okay.
So the visceral layer, which is the one that directly embraces these capillaries, it is having some cells that are called the podocytes. The podocytes, they embrace these capillaries and they have finger-like extensions that are called the pedicels. And these finger-like extensions open and close to allow the molecules to pass through this layer to go into a cavity that is called the capsular space. So the capsular space will capture the filtrate with its molecules. And then the space between the pedicels, it is known as filtration slits. So here is the ultrastructure of this part, the corpuscle. So this is the glomerular corpuscle magnified. So you can see this glomerular capsule or capsule of Bowman. This is simple squamous epithelium. And then this one reflects to cover these capillaries, branches of the afferent arteriole. So this is the afferent arteriole, forms this tangle of capillaries, which is the glomerulus. And then you have the visceral layer, which surrounds these capillaries, and you have these cells, which are the podocytes, with the pedicels that form the filtration slits. So this is an actual supermagnification of this glomerulus surrounded by these podocytes. So this is like the largest part, like the body of the podocytes, and this is the pedicels. And all of this space in between is the filtration slit. So as the blood is passing by through here, you filtrate plasma. And the plasma goes into this space that is called the capsular space. And then the blood will exit through this efferent. So notice how the efferent is narrower than the afferent. So more blood comes in, less blood comes out. That creates pressure. Under high pressure, we filtrate the blood. So that's the first part of the nephron. Now, the second part will be the tubules. The tubules have different parts. They have one part that is close to the corpuscle that is called the PCT, proximal convoluted tubule. Then the proximal convoluted tubule goes down, forming a limb, and then it goes and make a U-shaped turn. That will be the loop of Henle, and then has an ascending limb that goes up. And then that descending and ascending limb will make certain items to be absorbed, certain items to not be absorbed, and you can control many of these filtration process in this area. Now, in the PCT, internally, we have cells that are simple cuboidal epithelial cells with prominent microvilli. What is the function of microvilli in cells? Function of microvilli in cells. What is it? If cells have microvilli, what does these cells do? absorbs. So in the PCT, we have simple cuboidal cells to absorb most of the items from the filtrate. So we reclaim it. And then in the loop of Henle, the nephron loop, whether it's ascending, descending, or the loop itself, we have simple squamous epithelium. So this is where we have diffusion. And then in the DCT, or the distal tubule, we have simple cuboidal epithelium, and then we still have microvilli, but it's less abundant than the PCT. So in the PCT is where we absorb the most, and then when the fluid goes into the DCT, into the distal convoluted tubule, we can still absorb items if it's necessary. And we will see some modifications of this epithelium under the influence of hormones like aldosterone. So then this is the regional differences from these tubules. So we already saw this corpuscle. Now let's look at this PCT, proximal convoluted tubule. So if you magnify the wall of this PCT, you can see these cuboidal cells, simple cuboidal epithelium with a lot of microvilli. So this is where we have a lot of absorption. And then this PCT continues going down, forming the thin descending limb of the loop of Henle, which is made by, if you magnify this part, simple squamous epithelium. And then you have the loop itself, and then you have a portion that goes up that is called the thick ascending limb of the nephron loop. So if you magnify it, this will be simple cuboidal epithelium with no microvilli. And then if you go up, then you will form the distal convoluted tubule where you have simple cuboidal epithelium with very few microvilli. So if you compare, PCT has more microvilli than DCT. And then the ascending limb of the loop of Henle doesn't have microvilli, and this part, it is simple squamous epithelium, the descending limb. Now, between the distal tubule and the glomerular capsule, the glomerulus itself and the corpuscle, you have a group of cells that is called the juxtaglomerular apparatus, that is made by the juxtaglomerular cells in here. So juxtaglomerular because these are the cells next to the glomerulus. Remember, juxta means nearby. And the cells of this distal tubule, which are the macula densa cells. So this juxtaglomerular apparatus, what it does, it helps us to control blood pressure. So we have smooth muscle cells in the afferent and the efferent arterioles that are called the juxtaglomerular cells. When blood pressure goes down, you have less stretch of these smooth muscle cells, and then you send a signal, afferent signal, into your nervous system, and then that will trigger a mechanism to increase the blood pressure so that you don't faint. So you release a hormone that is called renin. Here, not a hormone, it's an enzyme. And that renin is going to start the cascade of the renin angiotensin aldosterone system. And then you increase the blood pressure. Now, for the collecting system, so just right after this DCT, you have the distal tubule that empties the filtrate into the cortical collecting duct. So the cortical connecting duct then will send this fluid into the medullary collecting system that you call it a medullary collecting duct. And then this system is going to empty into the papillary ducts And this, in general, in the medulla, since these tubules run straight, parallel to each other, they make this to look like if it was striped, the medulla. So this is the collecting system. So this will be the distal convoluted tubules emptying into the cortical collecting duct or into the medullary collecting duct and then into the papillary collecting duct. So this is the cortex, this is the medulla, and this is the papilla of the medulla. So what do you have in the walls of the collecting system? Simple cuboidal epithelium. In this case, these cells will have very too few microvilli, and then same for here. And this is low columnar epithelium, while this is simple cuboidal epithelium. Problems with the kidneys, you can have formation of calculi or kidney stones. This can happen because you have supersaturation of ions in the urine, like when someone is dehydrating, when they have a diet that is high in fat, animal protein, and salt and obesity. Crystals form in the tubules, and most pass unnoticed. However, when these crystals adhere to the epithelium, they form what is called the seed crystals that lead to the formation of stones. And they can damage the kidneys. So these stones can lodge anywhere. So for instance, in here, you have a kidney stone next to the renal pelvis. And that, of course, prevents urine from going into the urinary bladder. And that can lead to enlargement of the kidneys. And that has to be removed by surgery or by special techniques. So when someone has a kidney stone, sometimes they will have severe pain that is known as renal colic, and then the person may have blood in the urine if it damages the epithelium, and then leads to bleeding. And then the person will have sweating, nausea, and vomiting. And then the diagnosis is by doing what is called intravenous parallelogram, or IVP. So you inject contrast material in the venous system of the person, then you take imaging studies, and then you see if you have urine flow. So in here, what you can see is the urinary bladder is full with the contrast material. Okay, so percentage of nephrons. So we have 80% of the nephrons near to the cortex. So these will be the cortical nephrons. The other 20% will be juxtamedullary nephrons. There is a difference in the length of the loop between the juxtamedullary and the cortical nephrons. Cortical nephrons, they have shorter loop of Henle. Juxtamedullary nephrons, they have a longer loop of Henle that goes deep into the medulla, and they are surrounded, these nephrons, these loops of Henle, by capillaries that are known as vasa recta. And this vasa recta drains into the interlobular veins. So here's the difference between the two nephron types. Cortical, closer to the cortex, juxtamedullary, next to the medulla, which is this. This cortical has shorter loop of Henle. This one has a longer loop of Henle. And this loop of Henle in these juxtamedullary nephrons are surrounded by these blood vessels that are called the vasa recta, or straight blood vessels, while these ones are surrounded by branches of the peritubular capillaries. which are less straight than this. That's why this is called vasa recta, and this one's not. And then no matter if it's juxtamedullary or cortical, they drain their filtrate into, or their fluid into the collecting duct, which is this. So as you can see by the arrows. And then that's how you empty this. For the physiology and the formation of urine, so you have the first process, which is filtrating. So the plasma passes then through these filtration slits in the glomerulus. This is called glomerular filtration. And the fluid that exits to go into the glomerular capsule is called the filtrate. The filtrate will have water, will have electrolytes, will have acid, bases, organic compounds, like whatever you have in your blood, like glucose. You will have amino acids, and it has metabolic wastes. So all of that can be found in the filtrate. When the filtrate goes from the capsule into the PCT, the proximal convoluted tubule, it's going to change its name into tubular fluid. And then in the PCT, proximal convoluted tubule, you start the process of tubular reabsorption. So you will absorb water, glucose, amino acids, and electrolytes. So that will return into the blood. This is called tubular reabsorption. And this fluid, now it will be ready to go into the loop of Henle. In the loop of Henle, you continue with absorption of items, same as the DCT, and then you will start with the second step of forming urine, which will be secretion, tubular secretion. So anything that it is not required by your body will be removed from the peritubular capillaries and going into the tubular fluid. That can include toxins, hydrogen ions, or ions that you have in excess. So here is both filtration, reabsorption, and secretion. You exclusively filtrating here. So you have here your afferent arteriole bringing blood into the glomerulus, and then as pressure it is increasing here, you filtrate molecules from plasma, and then you end up with a fluid that is called the filtrate in this capsule. And then from this capsule, the glomerular capsule, the fluid goes into the PCT, where you reabsorb the most, as seen in green arrows. Green arrows means that you are reabsorbing and bringing these molecules into your efferent arteriole or into your peritubular capillaries. But first it has to go into this space, which is the interstitial space. So then you reabsorb here, and then you secrete. And then here in the loop of Henle, mostly you reabsorb. And then in the DCT, mostly you secrete from the peritubular capillaries into the lumen of the DCT, and you reabsorb very little. Now, up to this level, so here you call it filtrate, the fluid that is here. And then anything in the PCT, the loop of Henle, or the DCT, it is called tubular fluid. And then once the distal tubule drains its fluid into the collecting duct, then once the fluid is in the collecting duct, you call it urine. And then from the urine, you still can reabsorb items to go into the blood, and you can still secrete items. So you can secrete hydrogen ions if you have in excess, and then you can reabsorb water if it's needed. The filtration membrane that it is found in the corpuscle is made by the wall of the glomerulus, which is fenestrated capillaries, that has a width between 70 to 100 nanometers in width, the pores. So this one excludes the filtration of cells like platelets, blood cells, and proteins for the most part. And then you have the next part of the filtration membrane, which is the basal lamina, which is made by collagen fibers. And then this one prevents molecules from 8 nanometers from leaving, and molecules that are negatively charged, because you have negatively charged proteins that repels anything that has a negative charge. And then you have the other part of the filtration membrane, which are the podocytes that surrounds these capillaries. So you have the finger-like pedicells that can open and close, and they don't allow molecules larger than 7.1 nanometers to go through, like albumin. Albumin is prevented from entering into the filtrate. And then the filtration fraction will be the percentage of plasma that become the filtrate. So average is 20%, and the combined surface area of this filtration membrane is 6 square meters. So that's how we can filtrate a lot of blood, because 6 square meters, it's a lot of surface area. So this filtration membrane is just like the respiratory membrane. It's made by three layers. Basal lamina in between, sandwiched by the simple squamous epithelium of the capillaries and the simple squamous epithelium of the visceral layer of the capsule, which is the podocytes. So, something that the filtrate shouldn't have: red blood cells, white blood cells, bacteria. It shouldn't have large proteins like albumin. And then what it can have? Well, water, I told you before, organic molecules, inorganic molecules, can have nutrients like glucose, amino acids, and nitrogenous wastes, including urea, ammonium ions, which are basically waste products of the catabolism of proteins. And it also can include creatinine, which is a waste product from metabolism of muscle cells, and uric acid, which is derived from nucleic acid metabolism. So here is the filtration membrane. If you magnify this region, part of the glomerulus surrounded by these podocytes, this is what you will see. So this is the wall of the capillaries. This is an open capillary, so you can see these blood cells like the erythrocyte, the white blood cells. And this is the fenestrations of the capillary. And then you have the basal lamina, and then you have the pedicels from the podocytes. If you magnify this, you can see the fenestrations and then the filtration slits. So only small molecules can come in, but large molecules and cells, they're supposed to stay here. Albumin is a cutoff, because this space is no greater than 7 nanometers, and albumin is 7.1 nanometers, so it cannot pass through. And anything that is negatively charged it cannot pass through this filter. If you have prepare your own coffee at home with these filters, not like the pods, and then you have ground coffee, these filters, they have a specific pore size that prevents these grounds of coffee to go into your coffee. You pour the water, then you turn on your machine, the water goes through, and only water with the coffee flavor is supposed to go there, but not the grounds. Sometimes some people can have a disease or diseases that opens up gaps in here. This is called glomerulonephritis. So then proteins can go through, like albumin. It's like if you have your coffee filter and then you, with a knife, you open larger pores there. What would you expect to see in the container where you're grabbing your coffee? Grounds, right? Because they are very large. So that's what happened with glomerulonephritis. So you will have, here it is. So you will have molecules going through, especially if it's protein. The person, unfortunately, well, it's going to be protein. The person will have enough proteins in its blood. This is called hypoproteinemia. And then because proteins helps to maintain the fluid inside your blood, in your circulatory system, in your blood vessels, then the person's plasma is going to exit into the interstitial fluid, and then the person will have what is called edema, accumulation of fluid in the interstitium rather than being in the blood vessels. So then your filtration membrane becomes excessively leaky. And there are several causes of glomerulonephritis and different types of glomerulonephritis. And then substances can accumulate in the blood when someone will have problems with the kidneys. So we regulate the amount of filtrate that we produce because we have different mechanisms. So this is what we call autoregulation of GFR, which stands for glomerular filtration rate. So we have local responses that helps to regulate the amount of filtration. GFR remains constant if your main blood pressure, your MAP, mean arterial pressure, is between 80 to 180 millimeters of mercury. And we have a mechanism that is called myogenic mechanism. Myo for muscle. This works in seconds. So if you have an increase in blood pressure, that will stretch the wall of the afferent arteriole, and that will increase the GFR. Your muscles will detect this change in the blood pressure, and that is going to make your muscles to contract and then to constrict this arteriole, and then you will have blood flow decreasing through the glomerulus, which decreases the main pressure that we have in there inside the glomerulus, that is called the glomerular hydrostatic pressure, that going to lower the GFR. This glomerular hydrostatic pressure helps to bring out molecules or water from your glomerulus. Now, what happens when you have the opposite, when you have a decrease in your systemic blood pressure? Well, in this case, you have a reduced stretch in your walls of your glomerulus. That decreases the GFR. Your muscle cells will relax. That dilates your arteriole. You will have increasing in blood flow, and that raises your GFR. So you have the opposite effect. So that's the myogenic mechanism. We also have the tubuloglomerular feedback. That involves the juxtaglomerular apparatus. So, if you have an increase in your GFR, your flow of filtrate through the renal tubule will increase. And then if you have more sodium and chloride delivered into your glomerulus, into the macula densa cells in the distal tubule, where they are absorbed, you will have the release of ATP into the interstitial fluid within this juxtaglomerular apparatus. And this ATP is going to be converted into a signaling molecule, which is adenosine. And this will lead to the constriction of this arteriole, and then you will have a decrease in your GFR towards the normal range. Now, if sodium and chloride levels are high for more than a few minutes, something is going to happen with your macula densa cells. So you will signal your juxtaglomerular cells to reduce the release of renin, which is going to increase the GFR. And then these mechanisms, if they are insufficient to maintain the GFR when dealing with very large changes in the blood pressure, so for instance, if your blood pressure goes up above 180 millimeters of mercury, your GFR in the urine output will increase in effort to decrease the blood pressure. And then the opposite is going to be true. Let's say that someone has hypertension, the blood pressure drops below 70 millimeters of mercury. In this case, you will have less blood supply going to your kidneys, of course, and then your glomerular filtration will be almost null. So you won't produce urine, and this is called anuria. And this is just to help to maintain the GFR. Now, something that also influences the GFR is the diameter of the arterioles. So, of course, we know that this diameter, it is influenced by blood volume, but also other things can change this diameter, including the output of the sympathetic system. So for instance, when you change your diameter in your afferent arteriole, the arriving, and the efferent, it is nearby, it will adjust the size of this efferent in effort to maintain a gradient for the glomerular hydrostatic pressure, or GHP. So when either arteriole constricts or dilates, the filtration gradient changes. So, for instance, if your afferent arteriole increases in diameter when you have more blood volume, your efferent arteriole will either remain the same or increase the diameter. But when you have the opposite, when you have less diameter in your afferent, because you have less blood supply going on to your kidneys, you will have also constriction of your afferent, because you will have less blood supply. There is no purpose to have it dilated if it's going to receive very little blood supply. So, here is an example. So this is the afferent arteriole and this is the efferent. Regularly, this one, its diameter is smaller and this one has a larger diameter. So this one can constrict, you have less blood supply going on in here, and this one either doesn't increase its diameter or will maintain it, it will maintain it the same, or it will decrease its diameter. The purpose for this is to decrease the glomerular hydrostatic pressure because you have less blood supply coming into here, so you filtrate less. So both of them are correlated. When your glomerular hydrostatic pressure that pushes the fluid out of your glomerulus into the capillaries decreases, then this one consequently decreases. There is no purpose to create more urine when your blood pressure is down, because you want to increase your blood pressure by increasing your blood volume. And let's say that someone has increased sympathetic output that can affect the diameter of your efferent arteriole. Again, your efferent arteriole by itself is always smaller in diameter than this. But even if you reduce it more because you have your sympathetic system constricting it more, in this case, not only you'll have greater diameter of your afferent, but perhaps your blood volume is up. In this case, you have more blood supply arriving than leaving. That will increase that glomerular hydrostatic pressure, and that will increase your GFR. That increase the level of urination in effort to drop the blood pressure and drop the blood volume. And that is together with other mechanisms, like remember when you have increased blood volume, your right atrium distends more, and then you generate the atrial natriuretic peptide, which makes you to urinate more sodium, and sodium basically pulls water. So that's to control blood pressure. And then when you have vasodilation in here by itself, but no change in the efferent, you have in the afferent but no change in the efferent, that also increases your glomerular hydrostatic pressure than the GFR. And actually it's a little bit more than the previous situation because you have more blood volume going on in there. And then, again, this is when you have vasodilation of this, and then you have constriction of this for whatever reason. So you will decrease your hydrostatic pressure because more blood is exiting than entering, and then you have less glomerular filtration. And this is actually what happens with the release of renin. So when your blood pressure goes down, you have less blood coming in, and then this one distends less because you have less blood exiting. That will stimulate your juxtaglomerular apparatus, that will release renin, and then you start the renin-angiotensin-aldosterone system, or RAAS. And then I already explained you about the natriuretic peptide. So the RAAS, so this system can be triggered when you stimulate your neurons of the sympathetic nervous system, when you have low blood pressure, or when you stimulate your macula densa cells, when you have low sodium and chloride in your filtrate. Renin is going to activate a precursor of angiotensin 1, which is called angiotensinogen. We all have this long polypeptide in our blood that is called angiotensinogen. This enzyme is going to break it down to make angiotensin 1. And then angiotensin 1 is going to go into the lungs, and in the lungs we have this enzyme, angiotensin converting enzyme, that is going to convert angiotensin 1 into angiotensin 2. And angiotensin 2 is a powerful vasoconstrictor. So it's going to make your blood vessels to become smaller. And then this angiotensin 2 is going to activate not only vasoconstriction, but it's going to make aldosterone to be released by your renal cortex. So how powerful is this angiotensin 2? Is 40 times stronger than norepinephrine. So that increases peripheral resistance, which increases systemic pressure. And then something about aldosterone, once you release it, is that it's going to create pores in your DCT and even in your collecting duct that absorbs water. It's going to make aquaporins. And this aldosterone is going to also lead to the absorption of sodium and chloride, because chloride is going to follow sodium. Go and open, please. So this hormone, aldosterone, is known as salt-retaining hormone. And if ADH is present, antidiuretic hormone, you will have more increase in blood volume, because antidiuretic hormone prevents the kidneys from producing and releasing urine. Another thing that will happen is that you will stimulate the third center in the hypothalamus. So the person will be more likely to drink more water in an effort to increase blood volume. So function of RAS in general, maintain blood pressure over both short and long term, while preserving the GFR. So here is the general overview of this. Your liver produces angiotensinogen, which is a polypeptide that circulates normally in your bloodstream. And then when your blood pressure decreases, your GFR decreases, your juxtaglomerular cells releases renin, and then renin converts angiotensinogen 1 into angiotensin 2. Angiotensin 2 goes into the lungs. The lungs have angiotensin converting enzyme that would convert angiotensin 1 into angiotensin 2. Angiotensin 2 has several effects, including being a powerful vasoconstrictor and helping in the release of this aldosterone by your adrenal gland, which is going to lead to the retention of water and sodium and stimulating the thirst mechanism. So all of that increases blood volume, blood pressure, and normalizes homeostasis. We will see the rest of the chapter